Thank you for the invitation. My name is Dr. Sahena Haque. I am a consultant rheumatologist at the Manchester University Foundation Trust in the UK. I will speak on lung manifestations of GPA and MPA. So over the next half hour or so, I will discuss a number of cases with a focus on the management of lung diseases in ANCA-associated vasculitis. And at the end, I will discuss our approach to ILD predominant disease. So let's start with a case. This is a 31-year-old man. He presented to ENT colleagues with postnasal drip, nasal stuffiness, epistaxis, headache and right-sided hearing loss. His CT scan confirmed sinus disease and his CRP was high at 40. It wasn't until his third visit with the ENT team that the ANCA was checked, and I think this represents the difference in population of patients that we see. We might have checked that in the rheumatology clinic at the first visit. But unfortunately, the patient did not attend for his results for that visit. And in fact, he travelled to Pakistan to visit some family. Whilst there, he became quite unwell with cough, hemoptysis, and a rash. You may be able to appreciate on this chest X-ray some abnormality at the right lung base, and you can certainly see on the CT scan that there is a large cavitating nodule. There were some small ones in the periphery. So perhaps if I pause here momentarily and just ask you to consider what your treatment approach might be for this male with positive ANCA, ENT disease and a lung nodule. Would you opt for treatment with IV or oral cyclophosphamide, rituximab, azathioprine, methotrexate, or just steroids? Before I move on to the specific management in this patient, perhaps I'll take a moment to consider our general approach to vasculitis management. Of course, of all the patients that are referred to us, only a fraction of them will be diagnosed with vasculitis. So our starting point always has to be, is this actually vasculitis, or is there infection or tumour causing these manifestations? The next question is, how do we categorise the severity of this disease? And lastly, that will help us to decide which treatments to give. So for our patient, he's a young male, non-smoker. He had an extensive infection and tumour screen, which was negative. So his serology and clinical findings were in keeping with GPA. The next question is, how do we categorise this, this type of disease? And this UVAS categorization is helpful in patients with upper or lower respiratory tract disease without any significant systemic involvement. We would call this localized disease. Where there is constitutional manifestation without organ or life-threatening disease, we would call this early systemic. If there is significant organ-threatening disease, we would call this generalized. And if there is organ failure, we would consider this to be severe disease. It's helpful to consider those patients that have got progressive disease despite steroids and cyclophosphamide, and we would categorize them as having refractory disease. So for our patient, he had lung nodules and some systemic symptoms, but certainly nothing that is organ or life-threatening, and we would therefore characterize this disease as early systemic. So what would be our management approach for this type of disease? So if we first of all consider what the principles of treatment are for vasculitis, of course, the medical management is divided into two phases, the induction phase and the maintenance phase. The induction phase usually will include some steroids and the addition of another agent. The choice of that drug is dependent on the type of disease. Often these patients will have multiple organs involved, and a multidisciplinary team approach is very helpful. And we should be cognizant from the outset that both the disease and the medications that we give can cause significant complications, and we should remain mindful to try and prevent those complications where possible. So, in the context of early systemic disease, I will briefly describe this study, the NORAM study, which was published some 15 or 16 years ago now. And in this trial, there was a comparison of two induction regimes, oral cyclophosphamide compared to oral methotrexate for a period of 12 months, and then observation without any remission agent. And what this study showed was that remission was achieved in both groups. So methotrexate was as effective as cyclophosphamide. What this study also demonstrated was that without any remission maintenance agents, there is significant relapse at 12 months, and this was higher in the methotrexate group. We might also consider this study that compared mycophenolate to intravenous cyclophosphamide. This was more recently published, but the study was conducted some years ago. And in this study, there was an induction period for between 3 and 6 months, followed by azathioprine and prednisolone treatment for up to 18 months. And this trial showed that the two treatment arms were comparable in the first 6 months. However, once the steroids were weaned, there was a significant relapse rate, and this was higher in the mycophenolate group. So for our patient with early systemic disease, we opted for prednisolone and methotrexate treatment based on that literature. Once he was established on treatment, actually he had a very good clinical and serological remission. But he returned to the clinic 18 months later with a recurrence of nasal stuffiness and breathlessness. At that point, he had quite significant stridor, and though his ANCA did not become positive, again, his CRP did rise. You will see from this lung function examination that he has quite an abnormal flow volume loop, with depression in both the inspiratory and expiratory phases and quite a lot of flattening here, and that would be consistent with a fixed obstruction of the upper airways, such as tracheal stenosis. And this was confirmed in a CT scan. You can see quite a tight narrowing here, and the nice nasendoscopy pictures provided by my ENT colleague also confirm this. So he was treated with high-dose systemic steroids as well as local steroid injection. He had tracheal dilatation, which unfortunately was complicated in the short term with a tracheostomy. He also had grommet insertion for recurrent ear disease at that time. So if we return to our management approach, with this new flare of disease, we should consider whether this is still vasculitis, and his clinical features were consistent with a flare of GPA rather than an alternative diagnosis. We can then consider what the category of disease is now, and of course with tracheal stenosis, which can be life-threatening, we would upgrade this to severe disease. So what is our treatment approach for patients with severe disease? Perhaps I can ask you, just before I go into that, to consider again what your treatment approach would be for this patient, still our 31-year-old male who now has tracheal stenosis. Would you opt for IV or oral cyclophosphamide, azathioprine, continue with methotrexate, treat just with high-dose prednisolone, or add in rituximab? Would you opt for plasma exchange at this point? If we briefly review the literature of treatment of generalised or severe vasculitis, conventional therapy, of course, was with low-dose oral cyclophosphamide based on this NIH study, and what we know is that this was a very effective treatment, but did have significant related morbidity. More recently, we've had this trial which compared intravenous cyclophosphamide to oral cyclophosphamide for induction of vasculitis. And what we saw in this study was in that first year, there was no difference in time to remission, and the GFR improved similarly in both groups. However, in the longer run, there were more relapses in the intravenous cyclophosphamide group without any increase in death. But using pulsed cyclophosphamide allows us to use a lower cumulative dose with lower rates of infection and leukopenia. These two trials were published back to back over 10 years ago now, and they compared rituximab to oral cyclophosphamide in the RAID trial and to Cyclops regime in the RituxVas trial. And what these studies demonstrated was that rituximab without any maintenance agent was as effective as cyclophosphamide followed by azathioprine in patients with significant disease. So going back to our case, our preferred option at that stage might have been IV cyclophosphamide. But as it happened, he was still young and he wanted to increase his family, he wanted to have more children, and therefore wanted to avoid cyclophosphamide. And we treated him with rituximab with fairly hefty doses of steroids, and in fact he responded very well to rituximab reinduction. He did develop some steroid-related hypertension and diabetes, which has been managed very carefully and effectively. And the next question is, how do we now maintain this, this response? So if we consider the studies that have guided our maintenance therapy over the years, we can start with the Cesarum study. This was published in the New England Journal some years ago now. In this study, patients had induction treatment with oral cyclophosphamide and prednisolone for 3 months, followed by either continued cyclophosphamide or azathioprine. And this study demonstrated at 18 months that relapse rates were similar between the two groups. In the second study that I've mentioned here, the Wedgent trial, patients again had induction treatment with cyclophosphamide and prednisolone, followed by either azathioprine or methotrexate, and again relapse rates and adverse events were similar between the two groups. So these two studies showed us that methotrexate and azathioprine were equally effective as remission agents with fewer side effects compared to oral cyclophosphamide. More recently, there has been a trend to use rituximab as maintenance therapy, and this is based on this study in part. This is the main RITSAN study, where all patients had induction with cyclophosphamide, followed by either azathioprine or low-dose rituximab every 6 months. And what this nicely demonstrated is that over that 2-year period, low-dose rituximab was superior to azathioprine in preventing relapses. We've had some further follow-up from those initial 2 years from that group, and 60-month follow-up of those patients has demonstrated with that low-dose rituximab a low rate of severe hypogamma and similar infection rates between aza and rituximab. Within the rituximab group, there was a relapse rate of 23%, and relapses occurred between 18 and 24 months after the last infusion on average. You won't be surprised to hear that risk factors for relapse were PR3 disease, and a predictor of relapse was when the ANCA became positive after a period of negativity. So for our patient, we did treat him with 2 years of low-dose rituximab. He then went for 12 months without any treatment and then had a minor relapse, which we again treated with another dose of rituximab, and he remains very well on no steroid currently. So I'll move on to another case. This is a 63-year-old man, and he presented with cough, breathlessness, weight loss, hemoptysis, and trigeminal neuralgia. He was found to have nodules on his CT scan and was referred to the lung cancer service. He had a CRP of 300, and he was found to have a high PR3 ANCA titer. It was clear at the outset that his diagnosis was GPA and not lung cancer, and he was treated with prednisolone and mycophenolate. At that point, he had a degree of renal impairment, which resulted in the use of mycophenolate rather than methotrexate. He did well for about 6 months and then re-presented with cough and breathlessness. His CRP again jumped up, it was 250, and his PR3 titer went up to 10. But at this point, he grew pneumocystis in his sputum, and he was treated with Septrin. His prednisolone was reduced, and the mycophenolate was stopped, and he was switched to methotrexate at this point. He did well again for several months before returning to the clinic with cough, breathlessness, and weight loss again. Again, his CRP went up and his PR3 went up again, though modestly. And on this occasion, he grew Klebsiella, and this would prove to be quite stubborn. He had to have 3 courses of antibiotics before it settled. During that time, his methotrexate was stopped and he was maintained on 15 milligrams of prednisolone, with a plan to add in another agent. Before another agent could be added, in fact some 6 weeks later, he returned with a recurrence of cough and breathlessness and weight loss, and a bit of recurrence of trigeminal neuralgia at this stage. He again was found to be positive for Klebsiella. His CRP had risen, and this time his PR3 titer had gone up a bit more. And on this occasion, it was clear that he had not just infection, but also a flare of his GPA with new lung nodules on his CT scan, which didn't look purely infective. He was treated as an inpatient with intravenous antibiotics, was given 40 milligrams of prednisolone alongside that. And of course, when we have a flare of inflammation with infection, the management can be difficult to balance. But once his antibiotics were completed, we re-inducted with a course of rituximab. And in fact, this was a very good strategy for him. He went into clinical and serological remission. He's managed to come off his prednisolone. The plan was to give him some rituximab maintenance, but in fact his IgG was significantly low, and given his history of infections, we eventually decided to give azathioprine as a maintenance agent. And he remained very well for 2 years. In fact, he's only come back to the clinic in the last few weeks with a recurrence of cough that hasn't responded to antibiotics. And his PR3 has again gone up, and he's got new nodules on his scan, and we plan to give him rituximab imminently. But I think this case highlights very nicely that on each occasion when there is a flare of symptoms, we need to think very carefully whether this is a flare of vasculitis or whether there is an alternative diagnosis. So I'll move on to another case. This is a 68-year-old man who was presented in the last few weeks with cough, hemoptysis, and a vasculitic right heel ulcer. He had large hemoptysis, which dropped his hemoglobin significantly. He had arrived in his creatinine with some protein leak. The CRP was high at 249. His admission coincided with a second big spike of COVID at our hospital. Thankfully, his swab was negative. His PR3 antibody titer was very high, with a normal GBM, with a negative GBM antibody, and he quite rapidly became hypoxic. This was his admission chest X-ray, and you can see these widespread opacities. The CT scan demonstrates this diffuse ground glass appearance with multifocal consolidation. He was admitted to the intensive care unit. Thankfully, we have a fairly large intensive care capacity and managed to keep one of our intensive cares COVID-free, where he was treated. He was ventilated and had 7 plasma exchanges. He had IV methylpred and pulse cyclophosphamide, and actually he's done incredibly well. And after some complications over a 4-week hospital stay, he has been discharged over the last few days. I'll take the opportunity then to discuss this study, which examined the role of plasma exchange in severe disease. This is a PEXIVAS study, which was published in the New England Journal in recent months. This was a large study of 700 patients, most of whom had rapidly progressive glomerulonephritis, but there were a subgroup of patients with pulmonary hemorrhage. And what this study demonstrated was that plasma exchange as an adjuvant therapy did not result in lower instance of death or end-stage renal disease, but in that subgroup of patients with pulmonary hemorrhage, there was a signal for benefit. And it is still our standard practice for patients with significant pulmonary hemorrhage to treat with plasma exchange. Of interest in this study, patients were randomized to standard dose prednisolone or a low dose prednisolone regime, and there was no detrimental effect of the low dose regime. And given the degree of adverse effects that we see related to steroid treatment in these patients, this of course is a welcome finding. So I will move on to the last case now, and this is a 67-year-old woman. She presented with a 4-month history of myalgia, malaise and cough. She had a very high CRP on admission, and you will see here on her CT scan, she had diffuse alveolar changes, diffuse interstitial lung disease with ground glass and some subpleural consolidation in keeping with ILD. Her MPO ANCA was positive, but an extensive infection screen and CTD screen was negative. Perhaps we'll pause here momentarily to consider the treatment option for this patient with malaise, cough, ILD and MPO. Would you treat this patient with IV cyclophosphamide? Would you give her rituximab? Would you treat with mycophenolate, methotrexate, steroids alone, or refer for an antifibrotic? And I think these cases can actually be quite challenging. In our patient, she had a significant reduction in diffusion capacity, and so we were hesitant to treat with methotrexate and opted instead for mycophenolate with 40 milligrams of prednisolone. And that was a very good strategy for this patient. You can see here the pre-treatment CT scan, and the changes have largely resolved in the post-treatment scan at 6 months. We managed to wean her off her steroids altogether at that stage and have maintained her with mycophenolate since then, and she hasn't had any relapses since that period. This can be difficult because we know that a proportion of patients with pulmonary fibrosis with idiopathic pulmonary fibrosis will have an ANCA, typically a P-ANCA or MPO ANCA. But in that overlap group, there is certainly a group of patients that have ILD as a predominant feature of their ANCA-associated vasculitis. And this is of growing interest, but the evidence base remains limited to case series so far. And if we review those case series, these findings hold true in our patients as well, we see that patients tend to be older. In biopsy studies, the findings tend to be consistent with a usual interstitial pneumonitis or UIP pattern. The imaging tends to be very non-specific, and again we see that in our cohort with few patients that do meet criteria for CT diagnosis of UIP or NSIP also being described. These patients tend to have an MPO ANCA, but not always, and overall their outcomes can be worse from their vasculitis, with increased morbidity and mortality in these patients with ILD. There really isn't a good evidence base to tell us how we should manage these patients with ILD predominant ANCA-associated vasculitis, and within the literature, management strategies vary significantly. I think in our personal experience, we don't necessarily find rituximab in particular or cyclophosphamide to be particularly good strategies, but have been successful in some patients. We found mycophenolate, unlike other manifestations of vasculitis, we found mycophenolate to be a reasonably good strategy in these patients with ILD predominant disease, as demonstrated by the case that I presented. It can sometimes be difficult to tell apart these patients with idiopathic pulmonary fibrosis or ILD as part of an ANCA-associated vasculitis. We find that good discriminators tend to be fever and in particular a high CRP, which should not occur in the context of idiopathic pulmonary fibrosis. Within the literature, there is a description of an increase of neutrophils within the bronchoalveolar lavage, but also a description of eosinophil and lymphocyte predominance. We do lavage almost all of our patients in this category, and I must admit I don't find this a particularly good discriminator amongst our cohort of patients. So I hope this talk has demonstrated a range of lung involvement in the context of vasculitis, and that this can be common. It is important with each episode of flare to consider whether this is actually a flare causing these symptoms, or whether there is infection or tumour for that matter. And I hope also that these cases have demonstrated the value of managing these patients in a multidisciplinary team, and I conduct my vasculitis clinic with renal colleagues. I work very closely with renal colleagues, radiologists, ENT colleagues, and respiratory physicians, and I'm very grateful for their input with the management of cases that I have presented today. Thank you for your attention.